here.
Sure. Hello everyone, welcome to our Zoom meeting. Today we'll have 3 topics. Dr. Marina will moderate the meeting. Please go ahead when you are ready. Dr. Marina, welcome to the program. Thank you. Hello everyone.
Hi everyone. My name is Marina Das. I'm the canteen leader. I'm substituting for Marwa today. Today, the yellow team will be representing a few topics. Number 1 is chronic care management by Dr. Hafseena Noor. Number 2 is Covidence, that is the screening tool for systematic reviews, presented by Dr. Elmuiad. And number 3, urine analysis, presented by Dr. Asma Mohamed. And number 4, how to create animated explainer videos for patient instructions using tools like Proton or Animaker. And let's start and go ahead with the meeting. My first presenter will be Dr. Hafseena Noor on chronic care management. Dr. Hafseena, you can share the screen now and start presenting.
Am I audible?
Yes.
Are you able to see the screen?
Yeah.
Okay. So, Assalamu alaikum, everyone. First of all, before going into the presentation, I want to thank Dr. Nadir for giving this amazing opportunity. Also, I would like to thank the moderator. So, today, my topic is chronic care management. So the main idea behind this presentation is a shift from reactive care towards proactive and coordinated care, where we continuously support patients in managing chronic conditions. So I will start by briefly discussing what is CCM. So CCM is care coordination outside of a regular office visit for patients with 2 or more chronic condition expected to last at least 12 months or until the death of a patient, and that place the patient to significant risk of death, acute exacerbation, or decompensation or functional decline. It provides access to care outside of and in between doctor's visits. And one main important point is that it helps to reduce geographic and racial or ethnic disparities in healthcare access and coordination. Now that we have defined CCM, let's look at the types of chronic conditions who may need this kind of coordination. So these chronic conditions include cardiovascular conditions like hypertension, atrial fibrillation, and other cardiovascular diseases, metabolic disorders like diabetes, respiratory diseases like asthma and COPD, musculoskeletal conditions like arthritis, osteoarthritis, and rheumatoid arthritis, mental health conditions like depression, dementia, substance use disorders, autism spectrum disorders, and other serious conditions like malignancy. So what is important from a chronic cause perspective is multimorbidity. When a patient has multiple conditions at the same time and managing each one separately is difficult. And this issue of multimorbidity becomes particularly important when we look at the overall burden of chronic disease in the United States. So as you can see, 6 in 10 American adults have a chronic condition, which is approximately 117 million people. And 40% of Americans have 2 or more chronic conditions. 8 of the top 10 causes of death in 2021 were related to chronic diseases. People with chronic conditions account for approximately 90% of all US healthcare spending. Racial and ethnic minorities receive poorer care than white individuals on multiple quality measures, including chronic care coordination and patient-centered care. So now let's look at some of the core elements of CCM services. So the first element is structured recording of patient health information. Second one is maintaining comprehensive electronic care plans. Third is managing care transitions and other care management services. And finally, coordinating and sharing patient health information promptly within and outside uh, the practice. So the common thread across all these elements is that care becomes longitudinal and coordinated rather than being limited to what happens during a face-to-face appointment. So this leads to the chronic care model. So in the later part of the 20th century, researchers began to develop care models for the assessment and treatment of people with chronic illness. One of the most influential frameworks was developed by Edward H. Wagner and colleagues. You can see the model here. The 6 key elements needed to improve chronic illness care across different levels of the healthcare system are community, health system, self-management support, delivery system design, decision support, and clinical information system. So the central idea is that better outcomes don't come from simply having a better doctor. Instead, we need to create an environment with all these elements, and the productive interaction is the heart of this model, as you can see. So let's now look at these 6 components individually and see how they contribute to better chronic care. The first component is community, resources, and policies, which link patients to resources outside the healthcare system and supportive policies. Next one is self-management support, which help patients develop skills, confidence, and goals. Third is decision support, which is evidence-based guidance integrated into clinical practice. Fourth, health system organization, having leadership, culture, and structure, prioritizing chronic care. Next is delivery system design, planned proactive team-based care, leading to between reactive visits. Next, clinical information system, including registries, reminders, and data to identify and track care. So once we talk about this, it becomes clear that this cannot be delivered effectively by one healthcare professional working alone. So this brings us to multidisciplinary care. So here the team members, physician or an advanced clinician focuses on diagnosis, risk assessment, treatment decisions, and escalation. Nurse and care managers play a role in care coordination, monitoring, education, and follow-up. Pharmacists can contribute through medication review, adherence, and optimization. Dietitian or rehabilitation or behavioral health professionals through lifestyle, functional, and behavioral goals. Community and social care workers can help for navigation, access, social needs, and community resources. So the effectiveness depends on how well these professionals communicate and how well the team maintains this continuity. So let's have a look at the potential benefits of CCM. So for your patients, CCM can provide a team of dedicated healthcare professionals to plan for better health and stay on track. Also, comprehensive care plan supporting disease control and health management goals. Also gives access to outside resources, community support, referrals, and educational information. Additionally, support between visits and more frequent communication with providers. Also, for you and your practice, it helps improve care coordination and continuity, potentially improve in patient satisfaction, adherence, and care efficiency, potentially reduce avoidable cost hospitalizations and emergency department visits. Additionally, resources to support high need patients, potential operational and financial benefits. So what I want to emphasize here is the word potential. These outcomes are not guaranteed. They can vary depending on population, intervention design, and implementation quality. And one of the key factors that can influence this outcome is the patient themselves. So let's talk about patient engagement and self-management. Self-management means taking an active role in daily decisions and behaviors related to chronic conditions. Patients need practical knowledge on how to monitor symptoms, taking medication, recognizing warning signs, and know when to seek help. Education, coaching, peer support, and digital reminders can strengthen knowledge, skills, and self-efficacy. Also, behavioral support can help patients address the diet, physical activities, sleep, stress, and mental health alongside medical treatment. So, greater engagement is associated with better disease control, quality of life, and potential reliance on emergency care. One important concept here is self-efficacy, the patient's confidence in their ability to manage health tasks, which is a mediator of outcomes. So next, let's look at how technology fit into CCM. So one example is remote patient monitoring. So depending on conditions, patients may use BP monitors, continuous glucose monitors, pulse oximeters, digital scales for fluid retention, wearable ECG monitors. Another one is telehealth, which can improve access for rural and geographically isolated patients, reduce the transportation barriers, potentially higher patient and proving satisfaction. So this technology alone is not enough. The key question here is what happens to the data once we collect it. This brings us to the importance of data integration, electronic health records, and health information exchange. So electronic health records store your complete medical history in digital format. Your RPM data flows directly into your EHR, and this integration eliminates manual data entry and reduces errors. Whereas EHI, electronic health information exchange, allows different healthcare systems to share your records. When you visit specialists or receive care at different facilities, your providers access the same information. This coordination prevents duplicate testing and medication conflicts. So in the United States context, there is CPT codes and billing. So this reimburses providers for chronic case management through specific CPT codes that account for time spent coordinating care outside traditional office visits. So taking all of this together, the important questions becomes, is all of this effort actually worth it? So CCM may provide meaningful value to patients and health system, but benefits are not uniform across settings. So there is a personal attention and more frequent communication with the care team, greater support for self-management and care plan adherence, potential improvements in care coordination and patient experience, potential reduction in avoidable emergency department visits, hospitalizations and readmissions, and also potential improvements in quality of life and disease control. But again, these benefits are not uniform across every setting. So now how do we actually measure whether CCM works? So here we can look at patient-reported outcomes such as quality of life, patient activation, self-efficacy, experience, clinical outcomes such as HbA1c, BP, exacerbations and complication, healthcare utilization outcomes such as ED visits, hospitalizations, readmissions, and length of stay, economic outcomes including healthcare costs, cost effectiveness, and budget impact, implementation and equity outcomes including adoption, fidelity, sustainability, reach, disparities, and digital exclusion. So next comes the term implementation science. So we can have a look at some of the implementation outcomes, such as acceptability, adoption, feasibility, fidelity, penetration, sustainability, and some useful frameworks we can use as researchers, including CFIR, REAIM, Proctor implementation outcomes, normalization process theory, and some study approaches like pragmatic trials, hybrid effectiveness implementation designs, stepped wedge designs, mixed methods, and process evaluation. I am not going into the detail of each one. One important idea here is that a negative trial may reflect an ineffective intervention or an effective intervention that was poorly implemented. So this research perspective open up a number of opportunities for future research. I would like to share those with you. So one area of research is comparative effectiveness. Which cesium components or combinations work best for which population. And another area is multi-morbidity. Like we can do research on how can care models move beyond single disease pathways. And another area is digital integration. Do remote monitoring and AI-supported workflows improve outcomes without increasing burden? Next area is equity. Who benefits, who is missed, and how can digital exclusion be reduced? And one other area where research is needed is implementation. What predicts the adoption, fidelity, and sustainability across settings? And another important one is economics. What is the cost effectiveness and budget impact at scale? So looking ahead, there are many challenges and common failure points also. One major challenge is fragmentation. Separate clinics, records, and incentives can undermine continuity. And another issue is workforce capacity. Team-based care requires time, training, and role redesign. Next issue is data overload. More monitoring can create alert fatigue rather than better care. Another important issue is patient burden. Complex care plans can increase treatment workload. Another one is digital divide. Access, literacy, language, and trust influence uptake. Last one, sustainability. Pilot funding and enthusiasm do not always translate into routine practice. So these challenges can help us understand where the field of CCM is heading. So there are several important directions also. One is AI-assisted care, which risk prediction, clinical summarization, and decision support with strong governance. Also, remote and passive monitoring, continuous signals integrated with actionable care pathways. Next is personalized care plans, which is adapted to multi-morbidity, preferences, capacity, and social context. Inoperable data is also important. Longitudinal information connecting primary, specialty, and community care. Other one is learning health system, from routine data to evaluation to feedback and to redesigned care. Last one, equity by design. We can measure differential reach, benefit, and burden from the outset. So to bring everything together, I would like to finish with some main takeaways from this presentation. First, CCM addresses the reality that chronic illness is longitudinal, complex, and often multimorbid. The chronic care model provides a framework for redesigning care around prepared teams and informed activated patient. Next, effective CCM combines care coordination, self-management, support, multidisciplinary care, and reliable information flow. Digital health can extend care beyond visits, but implementation, equity, and workflow integration determine value. And next, Research should evaluate clinical outcomes alongside patient experience, utilization, cost, equity, and implementation. Ultimately, the next frontier is personalized, data-enabled, learning health systems that remain human-centered. So these are the references I used. Thank you. If you have any questions, I will be happy to answer those.
Thank you, Hafseena. That was a great presentation.
Thank you.
Yeah, very interesting and very commonly used topic. So I currently don't have any questions. If anyone else has any clarifications, they can ask. Okay. So we can move over to the second topic. Dr. Amr, are you available? Are you ready?
Hello, just one
Yeah.
minute so I can set everything up.
Sure. Dr. Amr
Thank you.
will be presenting on Covidence, which is a screening tool for systematic reviews. Yeah.
Is my voice clear?
Yes.
Yeah, we can see
Okay,
it. Yeah, please go ahead.
okay. Hello, everyone. My name is Dr. Amr. I hope everyone had an amazing week and is enjoying their weekend right now. Thank you for everyone for joining, and thank you, Dr. Hafseena, for the presentation. Thank you, Dr. Marina, for hosting, and thank you, Dr. Nadish, for your time. So today I'll be introducing Covidence, which is a research platform. We'll get into the details of it. But before I start, I'd just like to briefly speak about systematic reviews in general. And after that, it will become clear how Covidence helps us. So for example, let's just speak broadly now. Imagine we're asking a medical question. Maybe, for example, does telemedicine improve outcomes for elderly patients? Or does aspirin reduce the risk for secondary stroke? So these sort of medical questions, if you want answers for them, as evidence-based physicians, ideally most people would search PubMed, they would search some sort of research database, read a few papers, and try to reach a conclusion. But obviously, the problem is some papers will say yes, some papers will say no, some papers will say something in the middle. So how do we know which one to trust? That's why we create and value systematic reviews, because they don't rely on one study and instead they gather evidence from all the available data and evaluate in a structured, clear, transparent way, and draw conclusions based on all the evidence available. So researchers tend to need to sift through thousands of papers in order to reach a conclusion. And that obviously can be logistically challenging. So that's where Covidence and tools similar to it come in. So today, I don't want to show every single feature of the software, but I just want by the end of the presentation, everyone understanding how it helps and what you can use it for. So how can we define what a systematic review is? So many people just think it's a review of all the evidence, which is an oversimplification. To define it, you could say well, not to define it, but it's basically it's a form of research in the same sense you have case controls, cohorts, etc. You can think of it as a type of research, right? So for example, let's say there's 5 different hospitals and they do a study on the same thing. A systematic review would essentially be the summary and conclusion of all of those studies together, right? So for example, if one paper says there's this effect and the other says there's that effect, systematic review summarizes and evaluates all the data in in a reproducible way, which helps it become, more scientific and so that it doesn't have a lot of bias in it. So basically, if you look at the pyramid here, this reverse pyramid, so you have all the published research on a certain topic, and then the potentially relevant studies, and then you have to filter out even more for the studies that meet your inclusion exclusion criteria. And then at the bottom here, you have the studies that are included in the review. So out of the thousands of papers, only a few are actually the ones you'll actually evaluate and include in your study. So let's look at why systematic reviews are difficult. And this slide will help us explain how tools like Covidence help with this problem. So the first one is obviously time. A published systematic review can take anywhere from 1 to 2 years. So that's a lot of time. And that's not because the researchers are working slowly or they don't understand the science. Mainly, it's just because of the logistics. Every step in a systematic review requires careful documentation and a verification, etc. So all of that logistics takes and eats up a lot of time. Another reason is the volume. You can enter one search into one database and get tens of thousands of results, and you have to, in a way, go by most of them or all of them by hand. So obviously that can be cumbersome and tiring. Another thing is coordination. With research nowadays, you don't have to all be in the same room. You can have different authors collaborating on a project in different continents, let alone in different countries. So coordinating time zones and stuff like that is difficult and it takes a lot of planning and a lot of determination. Consistency. So while you're screening for papers that are relevant, you have to make sure that you apply the same rules and criteria to giving sort of paper preferential treatment. You have to be exactly fair. Documentation. So this is where the PRISMA guidelines come in. So basically, it's a way of verifying and reporting everything you do. For example, if you exclude a certain study, then you're going to have to explain why you excluded it. Or for example, if some study that doesn't really seem that it should be in your study and you included it, you also have to document and take note of that also. So basically, you can imagine all these problems, right? None of them are scientific problems. A lot of them are logistical and time-consuming, little small problems. So what is Covidence? So the easiest way I like to think about it, I like to think of it as like an airport. So does an airport determine where people travel? No. Does the airport make airplanes? No. But the airport is where travel occurs. So you can think of it like that. It's where all the logistics and coordination in making a research occur. So it's where the references can be screened. It's where disagreements between authors can be noted. It helps with the data extraction when you get to that phase of your systematic review. It helps with the study quality, and it also prepares a lot of the documentation needed for publication. So it helps with a lot of the tedious, tiring work that we don't really like to do. And it will become more clear as we go through the slides. So these are the steps of a systematic review. So before we dive into each stage, let's just have an overview of all of it. Even if you've never done a systematic review before, or this is the first time you're actually hearing about it like that, It'll be very clear. It's not complicated at all. So first you have to identify the studies, right? So you have a research question. An easy example is, what is the effect of aerobic exercise on systolic blood pressure in adults? So notice how that question is very specific. So your question in the systematic review has to be specific enough to get a useful answer, but not too specific where it excludes too many studies, because there's not a lot of studies that are done on the exact same thing. So it's a kind of art to get a broad enough question that's relevant, but a narrow enough question to actually get studies on it. So that's identifying. And then you screen the papers. Now, this is where Covidence comes in. So basically, you import all the references, all the citations, all the papers that you think are relevant, and then you import them into, for example, Covidence. So you and your research team can all have a look at the papers. And then you filter, and then you guys all read the abstract and determine if the paper is relevant or not. So for example, let's say we're doing the paper on effects of aerobic exercise on systolic blood pressure in adults. And then while I'm doing the screening, I see that one of the abstracts mentions that the effects are only diastolic blood pressure is measured, not systolic. So therefore, I can exclude the study in the screening process. I'm only looking for systolic in my blood pressure in my research. So that takes often a few weeks. And it's best if it's done by multiple texts of the papers, and this is unavoidable. But the nice thing is that you don't have to read the full text of every single paper you import. It's after the screening process, which trims down the workload a lot. So after you do that and you make sure you got your papers, then you extract the data. You'll have a look at how Covidence helps does that. And then you assess for biases in each individual study. And then at the end, you can finally report and publish a study. So let's start with identifying. So you import all your papers. You convert it into a suitable file type, and then you can just add it all into Covidence here. And then you start screening, right? So for example, look at this example here. There was 4,500 papers, and after they read the abstract and to check if they satisfied the inclusion or exclusion criteria, the research group determined that only 600 moved on to stage 3, where they read the full paper. So only 13% of the papers survived this. And here at the beginning, you had 6,000 papers. Now, if you're wondering where the 1,500 papers went, it's because on Covidence, they get rid of the duplicates for you. So when I'm doing the research, I have to check from multiple databases, right? I'm checking PubMed, I'm checking Embase, I'm checking Scopus, whatever. So I might get a lot of duplicates across those databases, right? So Covidence helps you get rid of those in the same way that your phone helps you get rid get rid of duplicate images. So it churns down a lot of papers that you wouldn't have to waste your time on. Obviously, you'll have to go about it. It doesn't delete them automatically, but it does, like, it's done by different people, right? So you can advise reviewer A in the screen all of them. That's a helpful thing also. So when they disagree, so let's say for example one author A said this paper should be included, it satisfies the criteria. In the same way that if two radiologists read a chest X-ray and one says there's a finding and the other says there isn't, they have to discuss and come to a conclusion so that an answer can be given, right? So after that, they discuss, they can have a few meetings, they can argue their case, and then eventually they either include or exclude it. This transparency is very important because when you publish a paper, a lot of journal editors ask about these sort of steps to show that the paper was done in a non-biased way and a scientifically reproducible way, so it could be published. So after we reach to the 600 studies, then we do the full text review of those 600, which does sound like a lot, but we started at 6,000. So we only have to read 10% of what we thought we needed to do. So it did help save us a lot of time. So after that, we could, for example, read the review, read the full text, and then we have to check if it still satisfies what we're trying to answer or not. And this is just a rough approximation. Let's say out of the 600, we have 85 remaining, 85 out of the initial 6,000. And every study you do end up excluding, you have to give a reason for it. Can't just exclude for no reason, because each study that is excluded will be logged and you'll need to have a clear explanation. Potentially, even years later, a journal editor might ask you, why did you exclude this paper? They have to have an answer for that. So after we have our 85 papers, now we start extracting the data. So Covidence helps you make this very user-friendly sort of data extraction tool where you can just enter it so you can get in a spreadsheet afterwards. Because obviously each study reports their findings in a different way. So by using this data extraction tool, you can standardize and have it in your nice little spreadsheet so it can be easy to view and compare. Now, after that, you're going to have to do something called assessing the study quality. Now, what this means is basically this is basically under the assumption that not all research is equal, right? Like imagine if I told you two studies reached completely opposite conclusions. One said that exercise helped with blood pressure and the other said it didn't. You automatically wouldn't trust them equally, and rightfully so. So you then ask yourself, how were the studies conducted? And that is basically stage 5 here, assessing study quality. So researchers use tools. There's one called the Cochrane's risk of bias tool to rate how much confidence to place in each study. So we don't just dismiss a study outright just because it doesn't meet the highest order of randomized controlled settings, but we do have to at least make note of it, right? So if you look at the slide here, we have like randomization process, that's a bonus. Missing outcome data, that's a negative. They measured the outcome, that's a positive. So this is a way of basically scoring each individual study so you can know how much to weigh it. And like I said, just because the study isn't perfect, it isn't automatically excluded. You just need to interpret the findings a bit more cautiously. So after that, this is one of the latter stages. You have to make sure that you report everything. And the nice thing about Covidence is that it does this for you. So you don't really have to worry about keeping a manual log of everything, right? You might have to enter the details, for example, of why you excluded a specific study in the text review. But at the end of the day, all the numbers are logged and tracked, and this becomes very helpful for you later. I'd like to go to the demo just so that everything I said makes a bit more sense. So I'm just going to pause screen sharing for just 1 minute so I can open the website. Is my screen clear here?
Yes, we can see it.
Okay, great. Okay, so this is what the website looks like. So this is, for example, the example I've been talking about, effect of aerobic exercise on systolic blood pressure in adults. So you import your references here. So let's just do an example. This is the free trial version, which only gives you 500 reports to add. So let's just add here, for example, we import this. And they already removed from me 16 duplicates that were already here. So let's look at the screening process, how that looks. Now, these are the papers I imported, right? So I have a look at the title, I have a look at the abstract, and based on the inclusion and exclusion criteria that I set with my team, I vote yes, no, or maybe. So this is talking about pulmonary hypertension, so I can vote no on that one. The effects of pre-exercise hyperventilation are repeated exercise sprint performance. So assuming this satisfies the inclusion criteria, I'd vote yes. Let's say this one is maybe. And then if someone were to vote no and I vote yes, it would appear here, and then we could discuss it out. This is what I was talking about, how it logs everything for you. So I imported 40 studies, 20 of them from PubMed, 20 from unspecified. I'd have to change that later. One was, and 19 duplicates were removed by the program. I manually removed one. And eventually, when you finish your study, you fill out all these numbers and everything will be automatically reported for you, which saves you a lot of time. So let's go back to the presentation. So obviously, we started earlier by speaking about the negatives or the difficulties of doing a systematic review. So now let's talk about the benefits of using Covidence. They basically solve a lot of the problems. So speed, it helps a lot with the manual tracking. You don't have to log everything manually, it's automatically done for you. Consistency, you make sure that the inclusion and exclusion criteria are fully met when you vote yes or no, and then you can hash out the disagreements with your colleagues. Transparency, so you make sure that it's very clear what you're doing so that you can't be accused of bias, and every decision you make has a reason and it's written down on the record. Collaboration, of course, you can't do a systematic review alone, and it can help you like collaborate with people across the globe and make it easy and streamline the work. Fewer errors. When you do it manual on a spreadsheet, it's easy to make a mistake every 10 minutes, but when the software does it for you, it's much more reliable. And like I showed you at the end, you have the Prisma Ready output, so you don't have to manually log it, and it's just all there for you. So let's look at some of the negatives. It's not free. I think it costs around $400 a year. So it's a bit pricey, but if you work with an institution, they say that usually they just charge the institution and the individual researchers can use the program. We already talked about these positives, and I wouldn't call this a negative, but some people assume that Covidence can do the meta-analysis, statistical analysis for them. It doesn't. I wouldn't call this a negative, but it is something you need to be aware of. It only helps communicate and facilitate the work. It doesn't actually do extra work for you. So just a summary here, systematic reviews are rigorous by design. That's part of the scientific process, and that's what makes them very valuable. Covidence doesn't replace the thinking, it organizes it so teams can focus on the judgment and the science behind the actual medicine, not the logistics, not the tedious tasks. Researchers choose it for the same reasons teams choose any good workflow: less friction, more trust. So like I said, just think of it as like an airport. It's where the traveling coordination takes place, and it helps streamline everything. So thank you everyone for listening. I hope it wasn't too long, and I hope everyone learned a thing or two. Thank you everyone.
Thank you so much. It was a great presentation, especially the live demo part, because that was one of the things I was thinking, how to use the software, and you demonstrated it in a beautiful manner. Thank you so much. Would it be possible for you to share the slides in the group so that we can look at it when, if required, or
Just share the PowerPoint.
share the slides.
Yeah, I don't mind, of course. Okay, sure, no problem.
Sure. Thank you so much.
Okay, no problem.
Okay. Anyone has any
Thank
questions?
you, Dr. Marina.
Yeah. Anyone has any questions for Amr, they can ask.
Thank you so much, both of you. This is great presentations, Hafseena and Amr. Thank you for sharing and presenting. Excellent work. Thank you. I just want to share.
Thank you so much, Dr. Nader.
You're welcome. If you want to share the file, you can do it also on the website or the app. So you go to the today's meeting, and then you can go to the agenda, and down here you can edit. And if you scroll down, you can have option to upload teaching file. Any one of these. If you have more, you can also add more options.
Yeah, that would be
Thank
great.
you, guys.
Yeah.
Okay, right away. Thank you.
Thanks. And same for Hafseena.
Yeah. If anyone doesn't have any questions on Covidence, we can move ahead to the next presenter, Dr. Asma Mohamed. She's presenting on urine analysis. Asma, are you there?
Hello, Mirna.
Yeah.
I'm there.
Yeah, please go ahead if you're ready.
Hello, everyone. Thank you for giving me this opportunity to present this topic, urine analysis. And now I'm going to share my screen. Okay, now my screen is clear.
Yes.
Okay. So today I'm presenting urine analysis. So I will go through urinalysis definition and components of urinalysis and importance of the urinalysis. First, urinalysis is a test used to urinalysis from the word itself. It is mean urine examinations. So urinalysis, it is a first line test used to evaluate kidney function and urinary tract health, and it is has three components: visual, chemical, visual. I mean visual gross examinations of the specimen, a chemical examination, which is urine dipstick, and microscopic assessment to look for any cellular abnormalities, any cast or any crystals. And the results of urinalysis is very important. It is help us to screen for any pre-existing condition, like screening for microalbuminuria for patients who have diabetes mellitus, or it also help us to diagnose many of conditions like the urinary tract infections, and also monitoring treatment response. So as I said, it has helped us to identify any urinary tract infections or inflammatory issues. Also, it is important, so it is in detection of any hematuria, proteinuria, which is give us clue about any pre-existing glomerular disease. And also, it is give clue about metabolic conditions like diabetes mellitus, because it is associated with glucosuria, and like DKA, it is associated with elevated urine ketones. So urinalysis is very important test or lab test. So But very important issue of urine disease is specimen collection and handling. So it is preferred to take mid-stream urine, and also to take morning sample, because morning sample it is give us concentrated urine. This it is allow us to estimate kidney concentrations function, and also it is allow us to trace to detect trace solutes that we couldn't find it on day specimen. Also, it is important to examine the urine specimen in the first 2 hours or first hour of picking the sample, because if it is took long time before examination, this will will allow degradation of some substance and give us inaccurate results. And also, it is important to use proper sterile clean container to prevent contamination. So, as I said, there's three components of urine analysis. First, macroscopic examination to look for color, clarity, and any visible abnormalities. And chemical analysis, which is dipstick assessment, and microscopic for cellular elements or cast. So, for color, the normal urine color is pale yellow to amber. And so, the color gives us or reflects hydration status. So very dark yellow, this is signs of dehydration. And also it is give us clue about any underlying condition, like if it is red color, it is indicates hematuria. And some UTIs affected urine color, like Pseudomonas, it is gives us green or blue urine. And also tea colored urine, it is a sign of jaundice or myoglobinuria. Also, it is important to note if there is any turbidity, or I mean the clarity is decreased. So turbidity is or cloudiness, it is important because it is indicates there is underlying infections or inflammation. So it is want us to for further investigations, like to do urine microscopy, and also to do urine cultures. So the microscopic examinations is very important because it is give us clue what is going on, and it is guide us to do further investigations. Um, so and also in also and clarity. Sorry, the other is urine dipstick. For dipstick, we look for leukocyte stress and nitrate. Leukocyte stress, it give us a clue about the presence of inflammatory cells like leukocytes, which is a sign of infections or inflammation. Also, nitrate is produced by gram-negative bacteria, and it is indicate that there is presence of bacterial infection. Also, dipstick it is allow us to detect any metabolic or renal conditions. For metabolic, we check glucose, ketones, and also protein and blood give us clue if there's any underlying glomerular conditions. Also, blood or hematuria, it is give us clue about if there's any urinary tract a problem, like if there is any infection, if there is any if there's any neoplasia, and also hematuria, sign of systemic conditions like infective endocarditis, and if there's any medication, anticoagulant medications. So it is really important. And also for it is allow us to detect if there's any bilirubinuria, any bilirubin in urine. Also in DP-stick, we detect we check for pH of the urine, and also for urine specific gravity. The importance of the pH, there's different urinary calculi occur in different acidity environments of urine. And also it is associated with urea splitting bacteria like some bacterial infections. It is associated with change of urine acidity. So alkaline urine more than 7, it is associated with urea splitting bacteria. And acidic urine less than 5.5 associated with ketoacidosis, with starvation, and with uric acid stones. Also, specific gravity is also important, because specific gravity, it is gives us a clue about the concentration ability of the kidney. So the normal range of specific gravity is 1.002 to 1.035. If the specific gravity is high, this is a sign of dehydration, sign of SIADA, and some contrast media cause high specific gravity. Low specific gravity associated with diabetes insipidus, associated with acute tubular necrosis. Just a minute, because my battery is going low. Just a minute, I will come to be in charge. Sorry for inconvenience. Just a minute. Also in DP-stick component, hello everyone, you hear me?
Yeah, please go ahead.
Yeah, okay. So another important part of urinary dipstick, it may detect any hematuria, and also if it is dipstick come positive for blood, this is not just because of red blood cells. There is other cause of positive dipstick of blood, hemoglobin and myoglobin. So to differentiate this, it is important to do microscopy to distinguish between hematuria or the cause, if the other causes of the positive dipstick of blood, like myoglobinuria or hemoglobinuria. Also, dipstick also, it is detect any protein abnormality. If there is any proteinuria, it will be appear in the urine dipstick, and this it is reflect if there is any glomerular issue like nephrotic syndrome associated with proteinuria. So proteinuria, it is warn us to do more investigation. It is importantly to do a quantification test for like 24-hour not 24-hour, to do albumin creatinine ratio to quantify this proteinuria. Also, dipstick, it is check urine glucose level, and if it is come positive, this may indicate glucosuria, and glucosuria, it is occur when the blood glucose exceed renal threshold, when it is more than 180 milligram per deciliter. And this warn us to do more blood investigation to check for more for blood sugar. Also, if we detected ketones on urine dipstick, it is give us clue about possible cause of ketonuria, like starvation, ketoacidosis, DKA. So each positive finding on dipstick, it is we have to correlate this with a patient symptom, with patient signs, and to do further investigation. So as I said, a specific gravity, it is reflect kidney ability to concentrate urine, and urinary pH also influence crystals formations. So on microscopy, we look for any cells, any bacteria. We look if there is any, if we detect any RBCs on the microscope, it is will give us it is support presence of hematuria. So it is differentiate the hematuria that if dipstick is positive for hematuria, the microscopy will differentiate hematuria from myoglobinuria from hemoglobinuria. So just a minute. So no RBCs, if it is more than 2 red cells per deciliter, it is abnormal. So this hematuria. Hematuria is more than 2 red cells per deciliter. Also, white blood cell, it is clue of UTI or any underlying inflammation, like pyelonephritis. Pyelonephritis. Pyelonephritis, sometimes it is if it is tubular necrosis, it is caused sterile pyelonephritis, which is presence of white blood cells without bacteria. And microscopy, it is really important for urinary tract infections because urinary tract infection, it is based on urine analysis and urine culture. In the urinary analysis, it is important to do microscopy and urine dipstick to detect UTI. For white blood cell, if we have more than 10 white blood cell, it is a sign of UTI. Also, if we detect any bacteriuria or bacteria on microscopy, this it warn us to do further investigations. Also, on microscopy, we look for any cast, if there is any cast, and to differentiate different type of urinary cast. And just a minute. So we have a different of cast, RBC's cast. This it is a sign of glomerulonephritis. If we detect any RBC's cast on microscopy, this is a sign of glomerulonephritis and renal vasculitis. Also, white cell cast, it is sign of pyelonephritis and tubulointerstitial nephritis. And There is a normal hyaline cast. This it is occur in the normal persons, and sometimes it is happen with exercise. Also, microscopy allow us to detect if there is any crystals, and also urine pH. It is predict types of crystals that is formed. So for urine analysis, it is important to integrate your examination or assessment. First, start by microscopic examination or visual examination, then urine dipstick and microscopic examination. So for urinary tract infection, it is presence of leukocyte, stress, nitrate, the white blood cells, and bacteria. All of these, it is signs of UTI. Okay, and also microscopic examination of urine. It is differentiate between RBCs associated hematuria from pigment positive like myoglobinuria and hemoglobinuria. And also this must be integrated with a clinical assessment. And protein deficit, it can be transient or can be caused by ongoing renal pathology like nephrotic syndrome. So if we detect any proteinuria on deficit, it is important to do quantitative tests to reveal the cause. And also microscopic examination of urine, it is give us about clue about if there is any presence of cast, which also indicate glomerular pathology. So sometimes we have false positive result and or false negative results. And like for dipstick, if we put the check for a long time, the reagent will be washed out of the stick, and this will give us false negative results. So it is important to handle specimen uh, correctly to avoid any false negative or false positive result. And it is important to do microscopy to confirm if any positive dipstick finding, like in hematuria, we have to do microscopy to differentiate a real hematuria from pigment hematuria, if there's any myoglobinuria, or if there's any hemoglobinuria. And sometimes if the result is unclear, so it is may be important to recollect sample and to repeat the test. So as I said, dipstick results may affected by also by urine concentration, because if there is diluted urine, sometimes it is give us false negative results. And also microscopy depend on preparation of sample, and it is important if we would like to detect any sediments, it is important to use a fresh sample. And if we can't examine the sample within 2 hours, it is important to refrigerate the sample for 24 hours. And after 24 hours, if we couldn't examine it, it is must be discarded and or to obtain new sample to examine it. Also, if we have a positive results of UTI, it is important to do if we have white blood cells on microscopy, or if we have positive nitrate, positive leukocyte stress, or bacteriuria. This is important to do urine culture to confirm the infection and to detect antibiotic sensitivity for treatment. And for protein, it is important to do quantification test. And if there is any inconsistency of the result, it is important to repeat the urine analysis. So this is all about that I will be prepared about urine analysis. I hope that this is clear and informative. And thank you, everyone. If anyone have a question.
Thank you so much, Dr. Asma, for also excellent presentation.
Thank you, Dr. Nadir. Thank you so much. And thank you, everyone, for listening.
Thank you, Dr. Asma. Now
Thank you.
we have to, yeah.
Thank
And
you. Thank you so much.
yeah. Anyone has any questions? Dr. Nadir, we can go over to for any project updates if anyone has so far.
Sounds good.
Dr. Amr, are you working on any project, any systematic reviews?
Yes.
Okay, good. Have you enrolled participants, or how is it going?
Do you have a team, Dr. Amr?
Yes, I can hear you now. What did you say?
Do you have a team?
Yeah.
Hello? I couldn't hear you.
Do you have a team, Dr. Amr? Do you have a team, or how
I
are
think
you?
I'm
How is
assigned
the
to the
progress
orange
going?
team.
Oh, okay.
I'm assigned to the orange team, yes.
Okay.
Anyone else working on any of new projects or projects that are ongoing? Anyone is working on mobile application or presenting a poster in the coming conferences, or any working on developing or designing posters? Or I know in August we have 2 posters will be presented at the conference in University of Michigan. Dr. Khalid and Dr. Noor will be presenting. Any one of the teams here? No.
Hi, Dr. Nadir. This is Avleen. I
Hello.
just recently joined. Yeah. So you said about the poster, right? So I can work on that if you want. Like I was
Yes.
not a part of the project though, but I can help out with the poster making. And whosoever wants to present, or if no one wants to present, I can present it because I live in Michigan only. So I can take
Yeah.
that from if I want to.
Thank you so much. And there are two people who are going to present the two posters. One of them
Okay.
is Dr. Noon. She is in Grand Rapids, and then in Grand Blanc, I think, in Flint area. And the other
Okay.
one, Dr. Khalid. He is also, I think, in Ann Arbor or somewhere. Where are
Okay.
you located?
So I live in Troy, Michigan. Like it's near Royal Oak.
Sure. So if you are free on August 4 or 5th, and the conference will be at the University of Michigan.
Okay.
So you might come and join, see how things going, and
Okay.
we'd like to welcome you to the program. So
Thank
yeah,
you. So I can
very
help them,
exciting.
right? If they are presenting. How do you know that?
Yeah, if they need any help,
Yeah.
I'll give you. If you can send me an email, I'll send
Yep.
you their emails, contacts, so that you will be in touch with them.
Okay.
I think they are just finalizing the design for the posters, and then they're gonna print and then take it there.
Okay. Sounds good. Thank
But
you.
you can work with them on practicing the presentation if you want to.
Yes.
Thank you.
That will be great. Yeah. Thank
Sure.
you.
Any other projects going on, or any new ideas, any updates, anything from you guys we can help you or you want to share with us? I know there are a few new fellows in the program, so welcome to the program. If you have questions.
I think Dr. Avleen Dhingra, she reached out to me as well as you. She wanted to be assigned in a group. She's not in any team. So if you could help
What
her.
the name again?
Avleen Dhingra. Avleen,
Okay.
you can, yeah, she just now talked with you. So she,
okay.
yeah,
Yeah.
you can reach out.
Yeah, sorry. I was not in any group, so I just wanted to like ask like which group I should join. Like there are multiple teams. Which one I should join?
So you are
Team,
supposed
yeah.
to be in red red 4.
Okay.
So and the Dr. Noon, Dr. Yusra Muhammad Khair is the team
Leader.
leader. Yeah.
Oh,
So I'm gonna share her information with you here.
thank
If I
you.
can get the chat. So this is her
But
email, phone number, and yeah,
thank you.
you're welcome. Anyone else with any questions or anything you want to share in the meeting? If not, I'd like to thank you so much, Dr. Marine.
Sorry, Dr.
Yes,
Nadir.
please, Rania, Dr.
Yeah,
Go
hi,
ahead,
Dr.
Dr.
Nadir.
Rania.
Yeah,
Hello.
I joined last week, and I sent Dr. Yusra because I am assigned for Red Team. I sent Dr. Yusra just today the email that sent me to in the chat last week. But I would like to know about the program of a geriatric program fellowship, about the lectures and all of. Shall I join each Saturday, or if there is any assignment for each group? I don't know about how can I join. It depends on the which group I join, or it's every Saturday I have to join. Really, I don't know about the program. Just for today, I sent her an email, and till now I didn't get any reply from her because just maybe 30 minutes ago. But I would like to know about the program because every Saturday I have to join, or I have to be with my team.
So first of all, welcome to the program, all the new fellows. So basically the program divided into different activities. One of them is this Saturday meeting where we have agenda, usually 4 or 5 topics, and these topics range from clinical. We focus on geriatric, but we can talk about other topics in other areas as well, or groups. We talk about technology, about use of tools like what we did today. Sometimes we talk about skills that you can improve on: presentation skill, confidence, and other professionality. And so we take it different. Let me give me a second. I'll answer this question, but Marina can explain more. Thank you.
Yeah, sure. So basically, every Saturday we have meetings, and there are multiple teams who have a leader, and they have assigned team members. So every week they are assigned to present on certain topics. These topics are already decided and on schedule already on the TGRF app. If you go onto the app and look at the upcoming meetings tab, you can see the every team has been posted, the leader's name has been posted, and the topics there are. So for the next week, you can check who is moderating the meeting and which team has the topics. Sometimes the team members or the team leaders do not find enough team members, or they are busy. So they sometimes post on the main WhatsApp group about the topics they want people to present on, and you can, if you can volunteer, you can pick up the topic to present also. The reason why we do this, because first of all, we have exposure to all the topics. We know how to coordinate. We get a feel of how it is done during residency. And secondly, these are recorded in the app. And when Dr. Nadir writes a letter, it can be very specific about what work you have done during the year, so that your letter of recommendation becomes personalized. And you have something to speak about in your interviews also. So it helps in both ways. That's what I feel. Yeah, Dr. Nadir can add anything else.
Thank you so much, Dr. Marina. Yeah, so this is regarding the Saturday meetings, and some of the topics can be shared like 2 speakers for the same topic if it's a big topic or something. The other point is, let's say if you are unable to attend the meeting, there is no problem. It's recorded, so you can watch the recording of the meeting at your leisure. You can go back to previous meetings as well to see how things are done. Another method that we do is divide you guys into teams. So the team, as Dr. Marina mentioned, is just to organize, but at the same time, some of the fellows in one team, they can divide themselves and they can work on a project together. Let's say you have an idea and you want to work on some systematic review. You can work with your team and divide that. You can be the leader for that project, or anyone with experience can lead that project. And that can be within the team. Sometimes this happened in the past. If the team is large, you can divide the team into 2 projects or ideas, and that also happened in the past. Like within the team, they have 2 groups. Each group is assigned or is working on different research projects. This is one of the things that can be done. Sometimes you don't have to be restricted to your team. If you are interested in a topic, let's say you are interested in nephrology, or Dr. Marina is interested in neurology. So you can, in the big WhatsApp group, you can say, I'm interested in this area. Are there any available projects that I'm going? So maybe Dr. Amro is working on neurology project with his 2-3 friends. So you can say, hey, I'm interested in the same topic. Then you can join Dr. Amr and then Dr. Marina as well if it's neurology. Or maybe Dr. Nadia is working on some projects about nephrology. Then you can join that project team and then work with them. Sometimes you may have an idea about how to do the step from A to D regarding the project, like Dr. Amro was mentioning systematic review now. So if you want to join the team and you have an idea, that's well and good. Go ahead and do the task and do everything. If you are new to the method or this type of research, then you can ask the project leader that I want to take one task. So your job is to basically do small task and then increase your experience next project, more tasks and so on, until you familiarize yourself with what the project entails from A to Z. There is another area where we are working on is the mobile development. So we are trying to develop some mobile applications, and if you are interested in certain area, and then there may be some group that are working on developing an app. For example, some are working on INR education app, or diabetes app, or hypertension, renal, fibromyalgia app. So in the WhatsApp, the big one, you can ask, is any of the mobile app available? So you can join these teams, and then you can work on any part of the project. If you wanted to test the project and the app, if you want to give feedback, hey, this color is not well, or this text is small, can you increase? Whatever user experience, like from the user prospect, you can add, or you can distribute the app later, or test the app, or work with the development team. And this can be listed in your ERAS application if you are applying for residency, or you can put it in your CV when you apply to other places, fellowship, or if you are, we have dental group here, we have therapist group. So anyone can join any of these mobile application projects and put it in their CV, and hopefully it will help some. Dr. Hayam is interested in dental app, so we are working on one of the dental app. It was done in the past, it was uploaded to Apple Store, but for 1 year or two, and then the Apple Store removed it. I think they needed some continuity, or they wanted to keep in touch with the project leader who uploaded that, and for some reason the app is not available there. So what we are trying to do is we are trying to recreate that app, and hopefully we can upload it to both Google Play and Apple Store again. So if you have new ideas different than that app, you can come up with like, for example, dental app for kids, something like that, if that makes sense. So your communication can be during using the big WhatsApp, and then targeting the team that are working on the app, or the group that's interested in that. Then you can work on that together.
Thank you so much, Dr. Nadir and Dr. Marina. But as I hear that Dr. Marina mentioned that there is a WhatsApp group, general WhatsApp group. How can I join this group?
So in the next steps email that I sent, it has a big WhatsApp group link. You can join that link, but any one of the seniors here, you can add or share the link for the WhatsApp group.
Yeah, I can add you.
Dr.
You can just send me a
In the chat?
text or something. Yeah. Send
Okay,
me a-
sure.
Yeah.
Okay. Thank you so much.
Yeah, no problem.
Okay. Any other questions or anything unclear? Or any new ideas? This program is for you guys, so if you think there are areas that we need to explore or try or add to the program, please feel free. Anything can improve your application, your life in general. Go ahead, Dr. Marina. Thank you once
No, I
again.
wanted to thank
If you
you.
have any
Yeah.
questions, go
No,
ahead.
I do not have any questions. I wanted to say the new fellows that if they have any ideas, they can post in the group and in the WhatsApp group, and people can collaborate together and they can ask help from seniors. Dr. Nadir is here to guide you. So you can attend the meetings, and in case you hit any bottlenecks or roadblocks, they can help you out. So, but it's a own initiative thing. You have to show initiative and work on it. So, it's lots of learning and help you'll get from your seniors and Dr. Nadir. That's what I wanted to say. Thank you so much.
Thank you. And one last thing I want to share is in the app, you can also see there is a way of adding when it's appropriate to request a letter. So you can add your activities, and then, as Dr. Maria mentioned, we will write you a letter that's personalized for you. So it's better to keep a record of what you did, what projects you are doing, and what things you are involved in. These are some of samples of other who wrote. I'm not sure if you can access them, but some of the fellows who matched in the past, they worked in different projects. They involved in webinars, in educational activities here, participating with presentation, mobile application, or conferences, papers, and abstract posters, something like that. So you can see we have different fellows with different types of activities. Sometimes it's only 2 or 3 projects they worked on, but sometimes they are involved in more than that, like this letter note, for example. So feel free to review this and see if you want to do any projects, and we are here to help you. And the more you have ideas and collaborate with teams, the more you will be able to do many things and list that in your CV. Sometimes a project might have different components, so if you want to get involved in one project and take one component, and that will be your part in the CV that you will talk about during the interviews. For example, my team and I, we were developing this mobile application for dental whatever care in kids, and my job was to review the app when it's done. I have no technical abilities to write the code or do the development as far as the app itself, but I was testing the app. I gave it to my friend, my family, my kids, and so on, and we tried it and we gave feedback and we improved it. Something like that, if that makes sense.
Yeah.
Go ahead, Dr. Marina.
No, I just wanted to thank. That's it. I think we are at the end of the meeting.
So thank you, thank you, Dr. Marina. I'd like to thank all the presenters from today's meeting, and thank you all for attending the meeting. And I'd like to thank those who will come later to watch the recording in the future. Thank you in advance. Assalamu alaikum. Fi amanillah.
Thank you so much.
Thank you
You're
so
welcome.
much.
Thank you, guys. So I'm gonna stop the recording. Dr. Malaz, do you have any questions?
Dr. Nadir, how are you? I'm sorry actually for joining late.
No, that's okay. You want me to stop the recording or we can continue?
Okay.